All right, we can go ahead and get started. So, this week's topic, we are continuing with the injury prevention efforts. And one of the first steps to that we talked about last week was the epidemiology and collecting the evidence there in terms of what is the most likely injury or illness that we are going to experience. And then we'll be continuing with preseason screening and how we can detect some of those things before they happen, or if they've already happened, they could be predisposed to further risk going forward. So the importance of the preseason screening and detecting those things early. So, give an overview. The purpose of the preseason screening or pre-participation physical exam is to determine what is safe participation in sports. And um, really, you can look at that one of two ways. You can say what constitutes healthy or what constitutes safe, or you can look at it the other way and say what is unsafe or what is unhealthy. And so, a lot of times, what is flagged on those pre-participation physical exams is actually a disqualifying condition. So if they have some kind of a heart pathology that is underlying and is detected, maybe through like an echo or an EKG, um, picking up on those things early and enough to make an impact or a change in terms of their participation. The risk mitigation. So a lot of times we're not necessarily preventing injury or illness, but it's reducing the likelihood of something catastrophic from happening. So, for example, maybe they have some joint laxity, and if we identify that in the preseason screening, then maybe we can prevent some further injury or instability if we provide taping or some kind of a prehab program where they're working on strengthening the surrounding musculature. Early intervention is something that would be considered to be important or something that will stem from the pre-participation exams. So, if you detect an illness or an injury, is that good enough? Probably not. You probably need to make some kind of a change that's going to reduce the risk to keep that athlete involved in the sport that they're trying to go out for. And then lastly, the process doesn't just stop after you've identified or started the early intervention. For example, if you have a an athlete with asthma, you're not just going to identify the asthma and then get them an inhaler once. No, you're going to you're going to monitor them throughout the season. You're going to do that regularly, either daily in some cases or weekly, sometimes monthly if you have some kind of longer term checkup with the physician who did the screening. But you're going to have some form of ongoing monitoring to make sure that the athlete is still safe and not at a greater risk. So the pre-participation physical exams, confusedly nicknamed PPE. Sadly, there are multiple acronyms in the medical field, and the sorry, I just got a notice from my computer that asked me if I'm still there, as if I'm not talking right now. um, yeah, there's a lot of medical acronyms that are PPE, so that's a bit confusing there. But they've been used regularly for about 50 years. The study that we will discuss later actually referenced it. It said 40 years as of 2014, and so 11 years later, 51-ish years. But point I'm trying to make here is that they've been used for a long time, and they've been used really regularly throughout any athletics program. They've been pretty much the staple of medical screenings. Uh, a complete medical history identifies about 75% of the problems. So that emphasizes the importance of collecting a history. It's not only just their personal history, but also the family history that puts them at a risk of some kind of an injury or an illness. The U.S. Preventive Services Task Force um, established criteria for what would be considered to be an effective screening. And basically, there were two components of that. One, it must identify the target conditions sooner than it would without the exam. So if you just let them go forward in their sport and then some kind of injury or illness reared its ugly head, then you would notice it when it comes up. So it has to be able to detect it sooner than that. And then the second thing is it must be accurate. So basically, what they're trying to do there is to avoid false positives. You're not trying to flag people for all these heart conditions and then get them to follow up with a cardiologist only to find out that there's nothing wrong with them. So you put them through further testing. Maybe you delay their participation in sport, and you can do a lot of harm by holding somebody out of their sport, especially if it's unnecessary. So making sure that the whatever screening tools you're using are accurate to avoid those false positives. For the literature review, the first one here, the does MSK screening decrease injuries? I thought was a really interesting read. It was a publication that analyzed the statistical evidence or success rates of musculoskeletal screening, and they basically assessed whether or not it was effective means of reducing injuries in the season. And I believe this study actually said that the MSK screening didn't decrease injuries significantly. So kind of raises the question, well, then why do we do it if it doesn't prevent those things? But Buddy Morris, the video down below, talks about injury prevention. And basically his take is that if you want to prevent injuries, don't play sports or stay on the bench. Basically his take is that you can't prevent injuries from happening completely. The nature of sports, you just can't prevent everything from happening. And it's such a chaotic environment that you're doing well if you can reduce the likelihood of injury. So basically, he says it's injury prevention is a myth. The American Football Pre-Participation Physical Exams is basically a more holistic take on the physical exam process from start to finish. What should be included in there? What should be the structure? Who should be applying these different tests? Where should be the setting, how many people at once, all of those kinds of things. And then it talks a little bit about the follow-up care after the entrance exam. So good holistic read there, a little bit of a longer study there. And then the last one that I have on here is the Mike Reinold has his podcast. And one of the episodes, they talked about how to build an injury prevention program, which touches on the entrance exams and a little bit of how you build the injury prevention efforts based around those entrance exam findings. So good topic there. And he's got a lot of different people on that panel. So good to hear different voices or different perspectives from different professions. So the publication review for this week, the NATA position statement on the pre-participation physical exams and disqualifying conditions. Basically what they established early on was that the problem that they were running into was that even though it was used for 40 plus years, there was a lack of standardization. And so this paper was meant to present athletic trainers with the content that's required for or suggested for their entrance exams, and then also how to administer them based on the location, the physicians involved, different staff that are involved, all of those kinds of things. They had a very thorough analysis of the quality of evidence. And so they also talked about the assumptions that come with the entrance exams. And basically they talked about what does make sense and what doesn't make sense according to the literature. So one of the things that was kind of interesting was when they were identifying those conditions that threaten the health and safety, they were talking about like the quality of evidence. And some of those points that they emphasized were that a physician, for example, should review all of the evidence, and they should review everybody's entrance exam thoroughly to make sure that it's accurately assessed. And that was only C grade evidence. So a lot of times the physician doesn't necessarily need to review that evidence if a medical professional of a different title is there to review that evidence. So the first part of it, again, this is not surprising to anybody who's ever done a physical exam. The medical and family history is the first part. So gathering a comprehensive medical and family history. Again, this will allow you to detect underlying conditions. And a lot of times this is probably your biggest predictor of injury or illness. So the study found that it was around 75% of all pathologies were detected just through the history alone. So definitely important to conduct this in terms of knowing what you're dealing with and preparing yourself for how to react when you see some of these things. The predisposal to injury, there were kind of two categories, and that they identified as strong evidence for likelihood of re-injury. One was previous injury, and then the second one was surgery. And basically what they suggested was, in the history, if you ever detect any of these things, you need to dig a little bit deeper than just the history. You need to have a thorough examination of these different parts. So if it's a previous knee injury, let's call it an ACL, and they had surgery. You don't just want to collect that and say, okay, they've got an ACL injury, so they're probably at a risk of another ACL injury. No, you want to take that in and truly assess the knee. Maybe you're doing an MRI to start the season to get a baseline. Maybe you're just doing a hands-on exam and getting a feel for what their knee stability is like, what their laxity is, so that if something happens throughout the season, you know what that is going to feel like. For the physical exam, they suggested starting with just the limited general physical examination. And so, what that includes is your vitals, your visual acuity, your cardiovascular screen, your neurologic screen, your gen med, and then your musculoskeletal. For the musculoskeletal specifically, they suggested having the 90-second MSK screening. And this was a finding from a previous publication, but it was found to be just a really quick screen. It's just a gross overview, but it was pretty sensitive. It picks up on about half of all existing conditions, and it was 97% specific. So if you find something in the musculoskeletal screening, it's probably relative to whatever the test is looking to identify. And again, they suggest if you find any kind of a red flag on this portion of the exam, then definitely need a further investigation, whether that's an MRI, X-ray, hands-on exam, whatever it might be. But they suggest starting with that 90-second and then going from there. Interestingly, I think that, they pointed out that one of the main points of success for a physical exam was that it should be conducted 4 to 6 weeks before the sports season. And nobody ever does this. Most people are doing it 1 or 2 days before their season. And one of the things they suggested was you do it in this timeline, because if you find something, it gives you time to do rehab, or it gives you time to do conditioning to prepare them for that season. So if they come in with something and maybe they're unfit, or maybe they have some kind of limited mobility, and you want to address those things before the season starts, so that when you start training, then you are healthy and normal. For the clearance portion of the exam, the suggestions here were to ask 5 questions. And again, they phrased it in a way that said the physician needs to ask these questions. But again, if you're an AC and you're reading or reviewing the entrance exam findings, you need to ask yourself these questions. Does the condition place the athlete at unacceptable risk? And so for most of these things, like for example, a lateral ankle sprain, unacceptable risk here would be something that's going to result in gross catastrophic event. So in most of the cases, a lateral ankle sprain is going to predispose them to further ankle instability. But are they going to dislocate? Are they going to have some kind of a limb loss because of this previous injury? Probably not. So unacceptable risk is going to be something more catastrophic, where they're going to have threat of either life or limb. Next would be, does the condition place other athletes at risk? And so maybe they have some kind of communicable disease that, if it's a bloodborne illness, is this going to place somebody else at a risk? So maybe they, or maybe they have some kind of a viral illness and they're need to be isolated a little bit. This was pretty prevalent in the case of COVID, especially when we weren't quite clear about the evidence on returning to sport after having COVID. So the cardiac risk there. And so if somebody had COVID at the time of the exam, then they probably should be held out, because it's going to put other athletes at risk. Next, can the athlete safely participate with treatment? And one of the things they were pointing out here, or emphasizing here, was like taping was one of the alternatives, or bracing in the case of a knee injury. So is some of that injury risk mitigated by taping or bracing? And they gave a couple other examples within the paper, but basically, if the athlete has an unacceptable risk, can that risk be modified by these different treatment? Then the next progression would be, can limited participation be allowed with treatment? And so maybe it doesn't reduce the risk completely, and maybe you still want to hold them out to a lower degree of training or game participation. And they suggested here for this one would be something like an ACL, and they're not quite fit yet, and they just need more time to develop the strength and the endurance, the capacity for sport. So, can they participate safely? Can they participate safely with treatment? Can they participate limited with treatment? And the goal there was to allow the athlete to be as functional as possible. Again, you don't want these false positives that are going to flag people or rule them out if it's completely unnecessary. And then the last thing they suggested to ask would be if a clearance is denied for certain sports, say like American football, which is a high risk sport for not only the cardio aspect but also the collision and the contact aspect. So they risk stratify within the paper, and they talk about high risk for cardio, high risk for contact. So if they're not cleared for American football, where there's tons of cardio and contact risk, what sports can they play? Can they do swimming? Can they do cross country? Can they do like one of the things that was on the lowest end of the spectrum was like playing pool or billiards? Can they do something like that? And so really, again, it's trying to keep people as active as they possibly can without just telling them, look, if you can't play American football, you're done. Like, don't play sports. So it's trying to work with the athlete and meet them where they are. So in summary, the purpose of the PPE is to determine safe participation in sports, which can be done inversely through identifying disqualifying conditions. And then one of the helpful components here is the medical and family history, the physical examination, the cardiovascular. You're going through all of these different components. But then at the end, if you identify anything through these initial screens, then you need to go through on the back end and do a deeper exploration here. And that could entail things like X-ray, MRI, maybe it's some kind of a cardiac follow-up, whatever it might be. And maybe it's a referral to a specialist. But whatever your findings are should direct your follow-up care. And then that should lead you to your injury or illness mitigation risk mitigation, and then also your ongoing care. And that should do it for this week. Next week, we'll be emphasizing kind of the follow-up care or the ongoing monitoring through the efforts of a prehab program and trying to prevent some of these unnecessary risks.